Given what Steve said when he did his medication and did his lovely diagrams about the brain, if we look at why does behaviour change, it does change as a result of brain changes. So you can imagine, when we talked about all those millions of brain cells that are in the brain all having this lovely job of doing stuff and keeping us upright, keeping us talking, keeping us breathing, if the brain is affected, there's no surprise that elements of our behaviour might change, yeah, if we're diagnosed with dementia. Now, not all behaviour will change because of the brain changes directly. Some of it will be about the fact that the person can no longer engage, react appropriately, make sense of, interpret their environment in the same way that they used to before. And if you're dealing with dementia on a regular basis, that will make perfect sense to you. Yeah? That way that you actually used to engage, the way you communicated, the way you had your needs met, actually have been affected by the actual disease process. Okay, so that's one of the things to remember. And I think it's quite important because when you're talking about behaviour and behaviour changes, I still meet people who think that people are doing things directly and on purpose. And so if you've got repetitive questioning or you've got other behaviours, often people will say, well, they're doing it on purpose, and I know. And actually, most of the time, I can't allow for every type of personality, because some people are going to be a little bit awkward and do things, but they probably always have been a bit awkward and do things naughtily. But actually, you know, that there is that physiological changes that causes those things to actually happen. Sometimes it could be that the activity is too difficult. One thing that we looked at once with a particular client was they used to be very, very good playing the guitar. And so when we were looking at things like hobbies and keeping people engaged and keeping people active, somebody said, oh, it would be great if we can actually get them back in and playing the guitar, because they were really good at that. But actually, the person got very angry and very upset about it because they had been such an expert at playing that musical instrument. When they were then posed with it again and started playing and realised that actually they weren't at the same level they previously were at, they didn't want to engage in that activity. So we have to remember that actually sometimes tasks are too difficult, or what we think is a good idea and it's going to be a good fit doesn't always work out that way. The other thing to remember is that dementia affects people in different ways. And one of the key things is remembering why someone's behaving in a particular way will give us an idea as to how we cope. Because I can't stand here and tell you, oh, well, if that behaviour happens, this is exactly what you must do. I could give you some clues or some indications, and that might work one day, but the bad news is it might not work next day. So I'm going to be realistic with you. Nobody is an absolute expert on behaviour because it changes and the circumstances change all the time. So there are some clues about what you can and can't do in relation to behaviour. If I could do it, I'd probably be really, really rich. But, it is a difficulty thing that we have to have. People have already said before that if something happens acutely, if something happens suddenly, it's a good idea to get medical attention. If somebody's behaviour changes quite dramatically in a short period of time, it's likely that there's an underlying physical cause. And people have talked a little bit about delirium, UTIs, you know, those sort of confusional states. Don't deal with that. Start seeking medical attention and getting somebody involved. It could be something else that's going on in the brain that's significant. So always, if things happen and change suddenly, then get somebody else to have a look. And also think about all the support agencies that are out there. And thankfully, you've got the local numbers on other slides. I have got the national numbers, but because I cover Norfolk and you're in Suffolk, I thought I gave you, my slides give you the national numbers, and they don't tend to change so readily as some of the local numbers do, or their services don't change as readily as well. So yeah, contact the organisations, see what is out there and what's there to support you. One of the things to think about is how do you manage behaviour, and the first thing you need to do, in my opinion, is look at problem solving. often people call it the ABC analysis. So actually they look at what's happening at the time or just before this particular behaviour, what is happening around the behaviour, and what are the consequences. So it's always a good idea to actually think about, well, how can I break this down? And one of the best ways to do it is to actually think, well, is this behaviour actually a problem? And if it is, who is it a problem for? Because sometimes people's behaviours will be, they might be a bit antisocial, they might be a bit difficult, but actually over a period of time they may also extinguish. Somebody who comes out with a particular behaviour doesn't mean that they're going to continue that behaviour for a long time. I'll give a really basic example. If somebody's started to do something like spitting, and they're at home and they've started spitting, and there's no real physical or medical cause for it, but for some reason they're spitting, if they're at home and you can put something down on the floor to capture those spits, that's okay. But if this person has to suddenly go into hospital and they're spitting on the bed that's next to them, that behaviour then is a problem. So you have to work out how big an issue is the behaviour. And one of the things that certainly the Alzheimer's Society has done is they've created a pamphlet around managing behavioural problems and psychological problems. And one of the things this pamphlet talks about is watchful waiting. Now, that was part of the drive to reduce the antipsychotic use nationally that they talked about earlier. But actually, we should watch and see how that behaviour carries on, and try and work out what is behind that behaviour before we start thinking about, is it a real problem? Does that make sense? Because sometimes it's not, and it will extinguish. It may be replaced by another behaviour, or it may not at all. And the other thing is the problem due to the environment? Is it a communication issue? Is it a misperception issue? Or has the person got an unmet need? So is the person in pain? Are they hungry? Are they thirsty? Are they too hot, too cold? But they can't express that because of the dementia. So it's trying to work out what that situation is. The other thing to think about is, when and where does the behaviour actually occur? So is it in relation to a particular environment, or is it in relation to particular individuals that may be around at any given time? When does the behaviour not happen, and what is that telling you? So if there's something else going on, for example, if the person is sitting in a room, there's not a lot going on, and they start to get agitated, is it because there's no stimulation for them? They're bored, there's nothing else to do, and so they find something else to do themselves, which is whatever behaviour they may exhibit, so shouting, screaming, however, trying to understand what that might be around. And do they behave differently according to the place that they're in? And can you see any patterns to the behaviour? Now, a lot of people will, a lot of professionals will actually stand back and watch. If you were asked to go into, say, for example, a care home and monitor someone's behaviour, you wouldn't just go straight in. You would spend a lot of time actually watching what goes on, and watching the interactions, and watching the environment, and watching the changes in that environment, to then see what happens with an individual's behaviour, to then make an assumption on why that might be happening, and what you might put in place to help manage that. And then the other thing to think about is what's actually happening for the person. So do they seem to be in pain, but they're not able to actually express that pain? Do they seem to be unwell? Is there a physical cause? Has something upset them? As I've said before, are they bored? Are they tired, anxious, frustrated? Are they involved in the world, or do they feel ignored? Are they actually linked into what's happening? Might they be hallucinating or in a delusional state, or do they seem to be depressed? Because the big mantra really is that all behaviour is a form of communication. It's just that we don't always pick up what people are trying to communicate. And that's the thing that all of these things are trying to do, is to actually work out what is behind that communication, and what's actually happening for that individual, because they may not be able to express it. So just getting on to some specific things. One behaviour could be that somebody has started hoarding, hiding and losing things. Why might that be? It might be because they're trying to control their situation. A lot of people with dementia start to feel that they're losing control over their lives and their individuality, and so often hoarding and hiding things is a way of keeping control. Sometimes people are experiencing paranoia or fear, worrying that their items are going to be stolen or somebody's going to come and take their things, and so they prefer to hide them up, and then they may forget where they've put them. As a memory issue, so forgetting the safe places, but I do this all the time myself, drive my husband mad. Sometimes people are feeling isolated, so they get very focused on themselves and so feel more comforted by actually collecting objects and keeping all the things close to them. And again, if people have rolled back memory, gone back to past times, where they may have had brothers or sisters that would take their things, they want to keep all their things together. It's a bit like, if you've got brothers and sisters that want to eat your Easter eggs, you hoard it all in so they can't have them. And again, something like feeding children, when maybe times were tight and they didn't have any money, and they very much had to make do. That's often a reason why. So some of the strategies, again, ask the question, is the behaviour a problem? If somebody wanting to hoard and hide things, is it a real problem? Try to understand the behaviour, learn where the hiding places are if you can, and check for missing items tactfully and discreetly on a regular basis. Provide a sorting box or a drawer if people like to have knickknacks and things to do. Maybe that would be better for them. Try and reassure them if they're anxious about their lost items, because people can spend an awful lot of time searching around the house looking for things, and a lot of upset can be caused. Unfamiliar environments can also result in hoarding. So if people are forced to go into different places, and you can find this sometimes when people are then expected to go into day centres and daycare, people sometimes start hoarding and hiding things at home. Store important documents, credit cards, etc. safely, because those are the sort of things that you don't want to be hidden up, and keep spare sets of things like glasses and keys and what have you. So trying to minimise the disruption caused by this particular behaviour within the household. Another one, for example, is repetitive behaviour or repetitive questions. One of the things, often this is due to memory issues, certainly in the earlier stages, but sometimes this behaviour is because people are feeling anxious or fearful. So to obviously keep asking questions is quite reassuring if you get the answer back. Sometimes it's because people are bored or they feel confused. So trying to understand where this is coming from is helpful. And then thinking about some of your strategies around being tactful and patient. It's really, really hard. I'm sure if you've had this, if somebody's asking you questions or doing repetitive behaviour, it's really, really hard sometimes to stay patient and calm. So many people that I speak to just say, I just want to flip my lid, it's driving me crazy. But you do have to respond as if it is the first time you've asked the question or the first time that the behaviour's been experienced. Because the person that's doing it often doesn't know they've done it over and over again, don't know they've asked the question over and over again because of the memory issues that they've got. Sometimes, I think you mentioned, writing things down was helpful, but actually over a period of time that's become less helpful, and that's not unusual. Using distraction or giving people occupation, people having a walk or a squeeze ball or a sensory cushion, a blanket or a rummage box, people having things to fiddle about with and do things, keeping themselves occupied is actually quite reassuring, relieves boredom and reduces people's anxiety and stress, which has a positive impact on people's behaviours. Meeting unmet needs like pain and hunger, always think about whether they're in the background, and sometimes using resources. So for example, if somebody's continually asking the time, give them a clock. It doesn't always provide the solution, but it might do for a period of time. Walking with purpose, previously called wandering. Reasons are often because people are trying to relieve their boredom or their anxiety. Maybe they're revisiting the past, think that they need to be somewhere, want to follow a previous journey they've been on before, trying to get some control and independence. Sometimes it's about relieving pain and trying to find their own occupation, really. And it is difficult because, as you've said, when people go off wandering and you don't know where they've gone to, it's quite anxiety-provoking. So some of the strategies, and they won't always work because your situation was particularly tense, would be around trying to find some stimulation, looking at physical and mental stimulation, perhaps looking at groups that people can be involved in. I don't know if you have men with sheds and things like that, but there are lots of groups that are male orientated that are coming through now. So trying to seek out things that people might want to do might reduce their desire to go off on their journeys and go for their walks, because they're getting involved in occupation and actually having some stimulation. Do they have any ID with them in case of problems? Do they have a regular jacket? If they do, put a little card in there, who they are and where they are from. Some people have walked onto the length wearing a badge or whatever, but that might not be appropriate. So some sort of ID. Trying also to think about assistive technology. You can get locator devices. So if they always have their phone, how can you link into GPS? Those sort of things. Think about what modern technology can do so that we can actually try and locate people. Because it's great if they can go out and do things while they're able to. You don't want to stop that happening, but you want the security and safety of knowing that they're going to be okay. Are they dressed appropriately for the weather? Have you got an up-to-date photograph of them? Because if you don't locate them, you're going to need a description if you're going to phone the police to help locate them. And also knowing what their patterns might be, doing your super sleuth and thinking, well, where do they like to go? Like if you're in a village, if it's the local pub was a previous thing they did, it's likely that they're going to go down there. Or did they take the kids to the school, and where is the school there? You know, that sort of journey. Even if the school's long gone, they actually still might go down that lane and those sort of things. So having some sort of idea about what might be happening. Distractions sometimes, if you don't want somebody to go out, think about what your distraction techniques might be to try and prevent them. It's not very helpful to hold on to somebody and say, no, let's go make a cup of tea, but trying to preempt it. If you start to see somebody's getting agitated and you think that the behaviour might result in them going out for a walk or wandering off, actually how can you distract it before that gets to that point? And sometimes you can disguise exit doors. So an example might be in a care home. They've covered a door with sort of like a big, looks like a bookshelf, but actually it's a door because they don't want the person to go through that door. Or they've used certain patterns on the flooring to prevent people stepping out through the door. But generally we're talking about in your own home, and it's less likely that you'll be able to think about doing those things. I haven't done an awful lot on aggressive behaviour because, as Maggie said earlier, aggressive behaviour doesn't tend to be a main feature of dementia. Certain types of dementia you may find people are more prone to becoming aggressive, but generally it tends to be people having an unmet need or a miscommunication. And us as professionals, carers, paid or unpaid, not getting that right. And sometimes that's not me being critical, that's what often causes people's behaviours to escalate to a point where they need to seek reassurance. And these are the main things. I think people have probably said most of this today. You can imagine that if people have got it's really hard for us actually to imagine what it must be like to have dementia, but really it must be very frustrating and fearful when the rules of engagement have changed, when the way you had a conversation, because if it is a memory issue, not all dementias come through predominantly with memory issues, but predominantly if it is a memory issue, how hard must it be to actually communicate? To communicate, you need to have an effective memory that's functioning really well. We take it so much for granted because we don't know what it's like not to have that. So we have to appreciate that actually it's no surprise that people do become agitated, frustrated, distressed, which might spill into anger and aggression if they're experiencing some of these things. And really, the main things to try if somebody is aggressive is, again, I go back always to try and understand what the need is, what's the person trying to communicate, approach them calmly, try to avoid confrontation, because even if somebody's memory is no longer intact, emotionally they are still very intact. So they will pick up on your body language, they'll pick up on the way that you speak, the tone of your voice, and how your whole body persona is. So if you go in a sort of like, I'm agitated and stressed by this situation, it's just going to escalate up. So try to avoid those things, try to stay calm, try to give explanations, try to go back to basics and think, well, actually, how important is this? Don't be confrontational, don't be argumentative. Most things don't really matter if you break them down. Try and be consistent in your approach, because if you're caring for somebody and there are other members of the family also caring, unless you've got consistency in the way that you approach the person and the situation, you're going to have problems created, no doubt. Yeah? If people are not on the same page, is what I'm saying, really. And avoid over-challenging the person. When Maggie spoke this morning, she talked about, people still having choice, but limit the choice. You have to change, because sometimes our communication, the way we communicate, it becomes too challenging for people with dementia to cope. So we want people to have choice, we want people to be engaged, we want people to be involved, but we have to make it as easy as possible for them to be able to do that. Has anyone heard of that term? When people appear to become more agitated and distressed, sort of like late afternoon, early evening. I don't think, there's been a fair bit of research, but I don't think anyone's actually got to the bottom of what it is. They talk about, when you talked about the light and the melatonin and everything else, there are certain rhythms that our brain follows, sort of nighttime, daytime rhythms. There's some thoughts that actually the physical changes in the brain affects those rhythms. And so that might disturb people as we go from daylight through to dusk, that people might become disturbed by that. There's also the thought around loss of routine, so sort of like late afternoon, early evening, we tend to be quite busy bees, rushing home from work, getting the tea on, kids' homework and everything else. And so that bit of time we don't usually register so much, because we're usually quite busy, and before we know it we go, oh gosh, it's 7:30 at night, I haven't even done this, I haven't done that. So there is some thought about that. Previously that was a busy time, and actually when you haven't got those things to do, there's not a lot else to do apart from maybe have your tea. So there is a thought about loss of routine. I've said about night before, it could be pain or discomfort. Maybe people are on medication and those medications are wearing down as the day progresses. And it could also be noise, excessively busy. One of the things around hospitals and care homes is that those things still happen, that the dinner trolley comes out, start getting people ready for bed, visitors start to leave, and also you find that those are problematic and people become agitated. And some hospitals have actually changed their visiting time accordingly to try and reduce some of the chaos that's caused, sort of like around the 5 o'clock times and 6 o'clock times in the evening. It's good to give people meaningful activity at that time of day, not over-challenging, not overstretching them, but preempting that this time of day might be a problem and finding something that they might want to do. Try and encourage good sleep, exercise, think about the environment, is it too noisy? Think about the lighting, is it too bright? Is it too dull? Because even without dementia, we all need extra light to be able to see as we get older. I think it's something like 20 or 30% more light is required for our eyes to function properly. Think about activities, reducing daytime sleeping, and again we go back to unmet needs of people are painful, hungry. It could be that somebody used to eat at 7 o'clock once the kids have been sorted, but actually when you haven't got to do all that stuff, 5 o'clock you might be quite hungry because you haven't got all those busy things to do and stop you've got thinking about your rumbly tummy at 5 o'clock in the evening, I don't know, but it's just trying to work it out. Another particular behaviour could be shouting and screaming for no apparent reason. Try and find out again, it could be pain or discomfort, it could be that somebody's hallucinating or misinterpreting the environment and they're feeling fearful. Could be that they're under or overstimulated. That kind of links in a little bit to just because I can shout and scream, which is self-validation. Sometimes there is no apparent reason for it, but people do it because they can. I'm still here, and can you hear me? That sort of thing, really. Again, we go down to the environment and looking at needs-based stuff, really. Can they see and hear? Juliet mentioned sight and hearing. There was one case, I won't mention where, but there was one case in a particular hospital that I worked in, and the person's behaviour was very difficult to manage. They were very distressed, and people started to say, well, actually, we think this person's got dementia. We need to start looking at going through that process of diagnosis. And actually somebody turned up and basically says, well, they haven't got their hearing aid or their glasses in, can we do that first? So they've got the hearing aid and got the glasses in from home, and actually the person's absolutely fine. They were just so deprived of their sensory, what we take for granted. They were so scared, they couldn't see or hear anything, they were struggling. So that shows just how important it is, really. Sometimes music and aromatherapy and massage and touch can help. It's quite interesting that there's been research that says that older people, and especially older people with dementia, become bereft of touch. Actually, we tend not to touch people as much as we used to. So massage and aromatherapy and things like those sort of holistic therapies do make a difference and can make people much less heightened and distressed. They can actually bring people down an awful lot. And also thinking about, is the room too dark? Are there mirrors that are creating shadows and things like that? People can be fearful. Certainly with dementia, when people have had that memory loss, it slowly erodes over time, and people start to lose their most recent weeks and recent years, etc., etc. That's why many people start to think that they're still 40 and the kids are still young and everything else. And often people will say to me, oh, you know, I've had to get out of my bedroom and go into the spare bedroom because he keeps saying, I'm not getting into bed with you, old woman, because that recognition is that he knows that she's someone important to him, so she can be in the house, but actually, I'm not married to you, I'm not getting into bed with you. So, yeah. And the best thing is to go into the spare bedroom if you have one and just leave it at that rather than getting into big debates. Some things to remember is that the behaviours most likely are not deliberate, don't take it personally, try and stay calm. Is the behaviour a problem? If so, for who? Encourage people to be independent, think about communication styles. There's a load of fact sheets, as people have mentioned before, on the Alzheimer's Society website, and if you don't access websites, then just phone them and they'll send them out to you to your address. And promote occupation. It's so important to actually, you know, if you sat in a room, if I said to you, right, go sit in that empty room, there's white walls and you're going to sit in there all day, you would start fidgeting, you'd start finding things to do, you might start singing to yourself, you would do something within so many hours. So occupation is so important in reducing some of the stress and distress that people feel. Avoid high challenge. So avoid lots of questions, avoid confusing sentences. What we might not think is confusing, actually for some people with dementia is very complicated and confusing. Try and think about what your expectations are. Are they realistic of that individual? Is it important that that person has a shave on any given day? Is it important that they have a bath? Is it really important that they do some of the things you might want them to do? Can it wait? Because later on in the day they might be more receptive to actually doing something you would like them to do. Reduce the stress, validate feelings and emotions, and think about their hearing and eyesight. Do they need to have those things checked out? Try and keep the environment unstressed, try and keep it calm, try and keep routines familiar. People often get very upset and agitated when the routine changes. And a lot of the time is that their coping strategies have found comfort within the routine. So try and keep the routine the same if you can. Think about your body posture, your voice, don't argue, and take a break and use support, which I think has been mentioned quite a bit today. And I always think it's quite nice to do this. It's easy for me to say this because I don't live 24/7 with somebody who has got dementia, but it's nice to remember the person with dementia is not giving you a hard time, even though it might feel it. The reality is the person with dementia is having a hard time. So if there's anything that we can do to try and alleviate that by thinking about all those strategies, you might find that it becomes a little bit more harmonious in the way that you manage and cope. And if you are really interested in looking at behaviours and environment, I would suggest you look at some of the research that's been done in Holland around the care facility out there called the Hoogway. Has anyone seen anything about that? That's not a professional person. Any carers seen that? I would look at that because actually there's a care facility in Holland where the way they care for people is very different to maybe some of our care facilities. And their incidence of distress, frustration and aggression is much, much reduced because they go for low challenge, in the way they approach people, and they accommodate people from their previous past experiences as well, and try and accommodate people in a different ways. First thing I'll say is I'm not an incontinence expert. There are continence services both in Norfolk and Suffolk, so if there are continence issues, I would always suggest that you speak to GP or speak to continence services in order to be able to progress things if there are continence issues. Many people will experience continence issues if they have dementia or problems using the lavatory. It's not always inevitable, but there is an increased risk of people having this particular issue. And brain changes, and again we've talked about people's perception, their ability to understand, to communicate effectively, pick up on bladder stimulation, all of those things can affect people's ability to be able to void appropriately in the appropriate places. Yeah? So all of those things cause those issues. Incontinence, sorry, I've lost the top there. What is incontinence? Well, it's the involuntary leakage of either urine or faeces from the body, and can be both. So it could be either or it could be both. There are common issues around continence. So you can have somebody who's got an overactive bladder. For some neurological reason, their bladders become very overstimulated, overactive, and so they need to go to the toilet. They get some intense urge to go, and they need to go frequently. Other people may have stress incontinence, so tends to be more common in women. We've had children and menopause and all those sort of things happen, and you get involuntary leakage of urine, especially if there's increased pressure like coughing or sneezing. So those are common types. And then you can also get overflow incontinence, where the bladder is full, but little bits leak out every now and again because there's a blockage somewhere in the urethral tube. So the tube going from the bladder outside tends to be common in men where they've got large prostates and things like that. So the first thing really is to find out whether there is a medical cause for somebody to have continence issues. So when these things start to happen, I would always suggest that you seek the GP or the continence services out. You can refer into continence services if need be. It's possible that there are treatable conditions, so it could be, we talked a lot about urinary tract infections, could be an enlarged prostate, could be something like constipation where somebody's getting overflow, could be side effects of medication, could be something like IBS, especially if they've got a historical background of IBS. It could be that that's a problem as well. And with IBS it would be that when you need to go to the loo, you need to go, you cannot hang on. But if you're not very good at communicating that because of your communication skills have become more problematic because of dementia, then you're not going to be able to just dash off to the toilet, especially if you've got mobility issues as well, so it may result in an accident. Key things to actually tell professionals. So if you're going along to a continence service, they would probably benefit from knowing things like the number of times per day the person is incontinent, whether it's urinary or fecal incontinence, when the problem started, whether the person's clothes are saturated or whether they're just producing a trickle at a time, if there's any increase in confusion or change in behaviours, if they apparently or they appear to have had fever or pain when going to the toilet, any medications, you should take a list of medications along, and whether the person passes urine in strange places as well. So if they're secreting their incontinence, as in they keep hiding all their clothes up somewhere because they know that they've wet them, but they don't want to really talk about it. So suddenly finding lots of wet pyjamas under the bed, or finding a pool of urine in the bin, or those sort of things, they would like to know about those things. Not being able to react to the sensation of needing to go because of the brain being affected by the dementia, or not recognising the need to go can be a problem. Not being able to reach the toilet in time, so as we all get older we get aches and pains, we have mobility issues, we may be in pain, and if you're not getting that message as clearly as you were previously that you need to go to the toilet, we usually allow ourselves good time to get to the toilet, knowing where the toilet is, how long it's going to take me to get there. Like in the break, you're thinking, well, do I have a coffee first, or do I go to the loo? It's fairly unstressed. But actually, when you've got dementia, you can't work those things out as clearly. So trying to get to the loo can be problematic. might not be able to communicate that you want to go to the loo, you might not be able to express that need, and you might be in a position where you're in unfamiliar surroundings. So by that I mean if somebody has moderate to advanced dementia and they're in this room, it's so unfamiliar they probably would never find that lavatory. Not understanding prompts to use the toilet. Difficulty with undoing clothing can be a problem, so often people will say we'll adapt clothing and use things like Velcro to make it easier to undo those things. Don't have too many fastenings and buttons and everything else that complicates the whole process. Not allowing or seeing the need for others to help. People often want to still be independent. They don't want to be embarrassed, and so don't want other people to help. And again, that's that difficulty about going from a relationship, as in son, daughter, wife, husband, to then going to, I need to help you get undressed and use the lavatory. Often people struggle with that. And as I said before, covering up the accident. So sometimes it's very hard to know that somebody's got a continence problem if they are doing that. Key things are to be sensitive to people's feelings, think about whether you need help and support with the situation, and once again you're building regular breaks and looking after yourself, because actually if you are dealing with this, can be pretty hard work. Identification of the toilet. So even in people's own homes, this is quite helpful to be able to put a sign outside the toilet on the door at eye line, identifying clearly that that is the toilet. Because sometimes you've got those long corridors in people's houses, if all the doors are shut, sometimes it's really hard to identify behind which door is the toilet. So a good sign. Try and keep the toilet door open and vacant. Try to think about the use of mirrors, not only because they might not recognise themselves, but they might think the toilet is occupied if they see sort of like a reflection in the mirror. So try to think about the use of mirrors. Maybe you need to think about sensor lights to activate when somebody's going into the loo, especially at night. Getting out of bed, is the bed height right for people to be able to get out of bed easily? Lack of privacy may inhibit the person using the lavatory. Think about lighting. Does the bathroom need adapting? I'll show you an adapted bathroom in a minute. Can they lock themselves in? Which is fine if they can, but actually have you got one of those locks on the outside that you can open easily if they're stuck in the loo? Because if you haven't, then I'd suggest take the lock off completely. As long as the door can shut, that's okay. But unless you've got one of those locks that you can put a coin in and turn it and get in there or something else, then I'd suggest that you don't have a sort of strong lock on the toilet door, really. And remove any objects that may be in place. So if you're in somebody's home or in your own home, you've got a potted plant there, you've got a stool there, all of those things, trying to get down to the loo, obviously remove those obstacles because it's going to make it that much harder. Communication, so simple words, maybe there's a particular word that somebody might use to use the toilet. Don't rush them, reassure them. It's much harder to avoid when somebody else is in the bathroom, but you may need to remain in the bathroom, so you might want to put a bit of water running, maybe a bit of music, just to make the whole thing a little bit more relaxed, and try and sort of develop a routine as well. And I'm not sure, but in some areas, I don't know about Suffolk, but in some areas you can also get a laundry service. Does anyone know? You haven't got one in? What about care homes? Any local care homes provide it? Because sometimes they do in areas. It's always worth speaking to social services if you're not sure, to ask them whether there are laundry services that you can pay for. And if you speak to continence services, you may be able to get disposable pads.
You just get assessments through surgery nurse as well.
Oh right, okay, surgery nurses as well. So you may be able to get, they'll deliver to the home, won't they, as well?
Yes.
So pads and things. Handrails, contrasting colours. By that I mean, if I think about my toilet is white, the seat is white, my sink is white, my bath is white, my walls are white. It's all very lovely for me, I like that, that's great. But actually, if you've got dementia, it's really quite hard to work out actually what the furniture is all doing. Contrasting seats, so a different colour toilet seat, so maybe a blue toilet seat, and think about your contrasting colours and not having shiny floors and all those sort of things, because people can misinterpret that for water and think they're going to slip, and just to think about how that bathroom is. And certainly I know in Norfolk that you can get a grant through the county council if you feel that your bathroom needs to be adapted. So again, I would also say that if you think you needed an adapted bathroom, then speak to customer first and think about social services. So So you may be able to get funding to actually be able to adapt it, and they'll come out and they'll think about what you may or may not need. This is an adapted bathroom, so yeah, the mirror is slightly covered over to reduce the sort of shadow of somebody looking like there's somebody in there, because if you walk past and you catch the mirror and you think there's someone in the loo, and actually it's you. Contrasting toilet seat, handrails, shower, easy to use, fairly matte floor, it's not shiny so it doesn't look like it's going to be slippery and watery, toilet, the seat in there, etc, etc. So just to think about how the bathroom is, to make sure it's actually fit for purpose and makes it easier to function, can make a massive difference as to how people function and use the toilet and the bathroom really.
So can I just say we've got an adapted bathroom, a wet room. We've got a raised toilet rather than the seat raisers and things. And the door has got one of those special catches from the outside that will open, so the door will open both ways. It normally opens in, but if you press the catch, if the door is shut while someone's in the bathroom, if you press the catch on the outside, it will open towards you.
Right.
Because as an ex-hospital staff member, the number of times that I've answered a buzzer when someone is in trouble in the bathroom and they're behind the door, and it is such a good idea. I mean, I call it a panic hinge. I've got no idea what the technical term is, but I call it a panic hinge because if anybody does get in trouble, you can open it from outside. It hasn't got a lock or anything on the door, but you can still shut the door.
And that peace of mind as well, isn't it?
Absolutely.
You know that's actually going to be okay.
You know, like I said,
there's a lot of technology stuff out there now around, you know, how we adapt the environment to make a difference, and it really does make it easier.
Yeah, absolutely. It's just that peace of mind. You know, that you can start the door shut. But if there is a problem,
you can get in.
I can get in from the outside.
If you need to. Yeah, absolutely. And again, going back to assistive technology, last time I heard you had stuff at Careline still, so always give them a ring and find out what's available, especially if you know whether or not you've got funding to be able to get those things in place. So they can look at things like, you know, incontinence sensors in bed, they can look at motion, lighting at night, all of those sort of things that make it easier. And it sounds like that's not very important, but actually makes a lot of difference to maintaining somebody's continence. And if you're in Norfolk, if you're in the Thetford area, you need to look at Enable. And again, the guys will come out with lots of advice and help you out. Nighttime problems, so you might think about commodes and bottles, if the commode is acceptable to the individual, because it's something unusual, they may not do well with commodes, so to think about that. Reducing drinks 2 hours before bedtime might help in reducing caffeine intake, and thinking about pads and protectors, as I've said. You don't want to limit fluids throughout your 24-hour period overall, just maybe before night. Goes without saying, washing and keeping people's skin clean and dry to avoid sores and problems there. When you're out and about, continence issues don't go away, obviously, so plan in advance, know where your toilets are positioned. Speak to the council, they should tell you where public toilets are. Take spare clothing and pads. Radar keys, has everyone heard of radar keys? So you might be able to access the radar key scheme, and also the Just Can't Wait card. So the Bladder and Bowel Foundation and Disability Rights UK will be able to support you with either of those things. Promoting a healthy bowel or bladder. It's really tempting, I think, for people to say, oh, well, they've got a continence issue, so I'm not going to give them so much to drink, but that's probably the worst you can do, because then you end up with an infection, and then you end up with other problems. So encouraging 6 to 8 glasses of water a day. Try to reduce things that are irritating to the bladder, so fizzy drinks and teas and coffees and stuff like that. Balanced diet, fibre, good for the bowels. Try and encourage mobility to reduce the risk of UTIs and keep seizing up, and that also encourages good bowel action as well if people are exercising. And where possible, keep a record of bowel movements. It's a good indication as to whether or not things are okay. It's easy to forget sometimes when people have been to the loo, so it's a good idea really to keep an idea of what's happening there. And then the last thing is that there are bound to be accidents. Try not to worry too much, but try to put some of those things in place to reduce the risks really. And then you're where to go for helps really, and they are, I've made them national numbers again because I didn't know whether we had a Suffolk, Norfolk cross divide audience because of Thetford, so I made them national numbers. So if you want to take those down, I'll leave those numbers out. And that's it.
Thank you very much.